Today's discussion is on brain abscess. Brain abscess is a localized zone of necrosis with a surrounding membrane within the brain parenchyma. The incidence of brain abscess is between 0.3 to 1.3 cases per 100,000 people per year. Development of brain abscess is most often associated with an underlying etiology. Those includes contagious spread from an associated infection, such as meningitis, otitis media, mastoiditis, sinusitis, soft tissue infection of the face or scalp, such as orbital cellulitis or dental infection. It might be direct compromise of blood-brain barrier, maybe due to penetrating head injuries or surgical procedures. It might be from embolic phenomena, from endocarditis. It might be from right to left shunt, mainly from congenital heart disease. Immunodeficiency and ventriculoperitoneal shunt infection can be a risk factor for developing brain abscess. Cerebral abscess occur in both hemispheres in children, but in adults, left-sided abscess are more common, likely due to penetrating injuries from right-handed assaults. Nearly 80% of abscess occur in the frontal, parietal, and the temporal lobes. In 80% of cases, multiple brain abscess are present, and in nearly 20% of cases, no predisposing risk factors can be identified. Abscess in the frontal lobe are often caused by extension from sinusitis or orbital cellulitis, whereas abscess located in the temporal lobe or cerebrum are frequently associated with otitis media and mastoiditis. When we came to etiology, the predominant organisms that cause brain abscess are streptococcus, which account for 1/3 of all cases in children. Staphylococcus aureus is the second most common organism in pediatric brain abscess. It accounts for around 11% of cases, most often associated with penetrating injuries. Other bacteria isolated from brain abscess include gram-negative aerobic organisms and anaerobic bacteria. But in up to 27% of cases, more than one organism is cultured, so the etiology is polymicrobial. When we came to the clinical manifestations of brain abscess, often the early stages of cerebritis and abscess formation are asymptomatic or associated with non-specific symptoms, including low-grade fever, headache, and lethargy. As the inflammatory process proceeds, vomiting, severe headache, seizure, papilledema, and the focal neurologic signs such as hemiparesis and coma might develop. A cerebral abscess is characterized by nystagmus, ipsilateral ataxia, and dysmetria, which is inability to control speed and distance, vomiting, and headache. If the abscess ruptures into the ventricular cavity, overwhelming shock and death occur in up to 27 to 85% of cases. Brain MRI with contrast is the diagnostic test of choice because it can aid in differentiating abscess from cysts and necrotic tumors. As an alternative, cranial CT can provide more rapid imaging results but cannot provide the fine tissue detail offered by MRI. Both MRI and CT scan with contrast can demonstrate a ring-enhancing abscess cavity. Regarding treatment, empiric therapy consists of a combination of third-generation cephalosporin, metronidazole with vancomycin, to provide coverage of methicillin-resistant S. aureus and cephalosporin-resistant strains of strep pneumonia. Metronidazole is to cover the anaerobic ones, and third-generation cephalosporin covers the most common etiologies such as strep. If resistant gram-negative organisms are suspected, as in the case of infected ventriculoperitoneal shunt, cefepime or meropenem might be used as the beta-lactam in the initial regimen. Listeria monocytogenes might cause a brain abscess in the extreme old group, in the old and also in the neonate, and if suspected, ampicillin with gentamicin is recommended. Aspiration of abscess is recommended for diagnostic cultures and decompression, unless contraindicated based on the location or the patient's condition. Small abscess under 2.5 cm in diameter or multiple abscess might be treated with antibiotics in the absence of drainage. When we treat with antibiotics alone, we should have to have follow-up neuroimaging studies to ensure a decrease in the abscess size. The duration of parenteral antibiotic therapy depends on the organisms and also response to treatment, but mostly it is around 60 weeks. Currently, with current modality of imaging and the treatment, the mortality rates range from 5 to 10%. Factors associated with high mortality rates at the time of admission include delayed administration of antibacterials, age less than 1 year, multiple abscess, and the comat presentation. Long-term sequelae occur in about 1/3 of the survivors include hemiparesis, seizure disorder, hydrocephalus, cranial nerve abnormalities, and behavioral and also learning difficulties. Thank you for watching.